Good evening, everyone. I hope everybody can hear me. I'm Dimitrios Kostopoulos, and on behalf of Hands-on Seminars, I would like to welcome you all in this webinar tonight. Before taking the opportunity that some of the people are in the process of joining us, I would like to let you know that on the right-hand side of your screen, you have a dashboard that you can use to ask a question. There is a special section in the lower part of the dashboard where you can actually type a question. I will take the time at the end of the webinar to answer to as many questions as possible. At the same time, you can, if you want to see and watch this webinar again in the future, or if you have any colleagues who do not make it tonight and would like to attend this webinar, they can attend it via a link that will be available to everybody. At the end of the webinar, I will let you know what you need to do in order to obtain your CEUs. Tonight's webinar will deal with advances in manual therapy in the area of cervical spine pathology. I would like to let you know that the materials will be presented tonight have been developed by myself and my associate fellow Konstantin Rizopoulos from Hands-on Seminars. So the first thing I would like to ask you is whether you have do you currently use manual therapy techniques in your practice? I would like you to answer this poll that appears in front of you, I guess, now. Okay. So that's a quick question. Just a click on the answer, whether you use manual therapy currently in your practice. And I will let you know what have you answered. Okay, so 80% of the people who are attending, they do practice manual therapy. 10% they don't, and another 10% they do, but they don't feel very confident, and they would like to learn more. This is the results of this poll. Okay, so very quickly, I would like to let you know that one of the major differences that Hands-on Seminars has in comparison to other manual therapy courses and programs is that at Hands-on Seminars we believe that one specific manual therapy approach cannot be the answer to all patient musculoskeletal problems. You see, many years ago when we developed these programs, we realized that in the clinic we do not treat patient problems utilizing just one manual therapy approach, but rather a combination of approaches. So when we developed Hands-on Seminars and the MCMT program especially, we created what is called the manual therapy toolbox, where we utilize a variety of manual therapy approaches rather than one specific approach. So in our courses, we utilize myofascial trigger point therapy, muscle energy techniques, strain counter strain, mobilization, manipulation, neural mobilization, proprioceptive training, and stabilization. And tonight we will take the opportunity to discuss on a specific patient case about the three first approaches: myofascial trigger point therapy, muscle energy technique, and strain counter strain. And before that, I would like to ask you and find out how many of you have taken a course previously with hands-on seminars. Okay. So about half of the people, 42%, have taken a course with us, and perhaps some of the information that you will hear tonight, those of you who have taken a course with us before, the information may sound very familiar to you. So moving on. We will discuss, we call this clinical case the essential troublemaker. This is a case of a 72-year-old female who was a driver and she got involved in a motor vehicle accident. It was a frontal collision and she sustained fractures in the cervical spine. She had a surgical intervention with internal fixation. And when she presented to us, she had significantly decreased range of motion, pain along the cervical spine, but also pain around the eyes, blurred vision, occipital and frontal headaches, and no significant other abnormalities. So this is actually the patient. This is the case. This is actually the areas where the fixation was placed. And this is the cervical spine. This is her side bending and rotation, extremely limited, as you can see. That's her side bending from a posterior approach, posterior view, and this is the flexion. You can definitely see the flat cervical spine and the extremely limited extension of the cervical spine from the side view position. You can definitely see the hump in this transitional zone, the area of the lower cervical upper thoracic spine. We call this the transitional zone, where a highly mobile cervical spine area meets a very stiff and stable thoracic spine. And on those patients with cervical spine pathology and muscle imbalances in the cervical spine, we usually observe this hump in this transitional area. Now, in terms of epidemiology of the cervical spine, in the United States alone, we have over 1 million cervical hyperextension injuries. 20% of the automobile accidents involve some sort of pathology of the cervical spine. Women tend to have a greater incidence of cervical spine pathology relative to men, and this herniation usually in the segments of C5 to C7 would be the most prominent ones. Also, excessive lifting, smoking, diving, posture, and of course direct trauma of the cervical spine tends to be blamed for the overall cervical spine pathology. So here is another question for you. Which of the following muscles do you believe that would be mostly involved, abnormally involved in this specific patient? Definitely some more than one muscles will be involved in this, but which specific muscle would be mostly involved? I see that some people are taking extra time to think about this. We're not gonna quiz you. There is no right answer or wrong answer, but you will be able, definitely all of you, to answer this question in a few minutes after I finish the presentation. So 53% of you correctly shows the sternocleidomastoid muscle and definitely the cervical paraspinals as well as the levator scapula, and frankly the thoracic paraspinals and the temporalis will all be involved. But as you will realize in a moment, because of the specific symptoms that the patient presents, it is the cervical, the sternocleidomastoid muscle that in this case will be mostly involved. Let's look at this case of a 35-year-old male who happens to be a frequent computer user, presenting with headaches in the front and back of the head, with pain around the eyes, as you can see here, earache, blurred vision, and tinnitus. This is very similar to the real case I presented to you before, because this case actually is out of our textbook. It does not represent a real case, but it is very, very similar to the patient who was involved in a motor vehicle accident. So what happens if a patient goes to a physician exactly with these symptoms? Well, the physician is going to perhaps suggest that the patient may suffer from migraine headaches. Maybe there is a hormonal imbalance. Maybe the patient, as differential can be used, a facial atypical neuralgia. Or is it possible that this patient may have a tumor, an acoustic neuroma, a schwannoma, or it's just stress and that patient needs to see maybe a psychiatrist? So depending on what the physician will decide as differential diagnosis, they may decide to actually give to the patient just some drugs and have the patient wait and see what happens, do some lab workup for hormonal imbalances, brain MRI, Doppler test, or send them to a psychiatrist. But what if I tell you that a specific muscle, in this case the sternocleidomastoid, is responsible for this patient condition? And what if one specific clinical examination alone can identify the patient problem without having to do MRIs or other expensive testing? So indeed, what we're talking about is the presence of myofascial trigger points within the sternocleidomastoid muscle. So what is a myofascial trigger point? The first person who truly defined the myofascial trigger point in the literature was Dr. Janet Ravel, who used to be actually the White House physician during the JFK administration. So Dr. Ravel, she was working on a patient with an infraspinatus problems, and she was doing a biopsy in the infraspinatus muscle. And during the biopsy, when she put a needle within the infraspinatus, she was able to identify that the patient was complaining of pain in the front of the shoulder. So this pain in the front of the shoulder, while she was putting a needle in the back of the shoulder, in the infraspinatus muscle, did not follow any dermatomal or myotomal distribution. And therefore, she started wondering why that pain in that area. So that's how she started with her research until she got to actually define a myofascial trigger point as a highly localized, hypersensitive, and hyper-irritable spot. Now, we believe that the myofascial trigger point is not just a spot, it is rather an area of hypersensitivity, an area of hyperirritability instead of just one specific spot. So it is, today we believe that it is a misconception to think that the myofascial trigger point is just one little spot. Of course, as that area, as we go towards the center of that area of hypersensitivity and hyperirritability, the symptoms will be greater, and obviously that will demonstrate that the hyperactivity of that phenomenon is towards the center of the hyperirritable area. In our 2001 book, The Manual of Trigger Point and Myofascial Therapy, Konstantin and myself, we introduced a few new things in the literature. The first thing was that we integrated myofascial trigger point therapy with proprioceptive training. We gave tremendous emphasis in the area of the biomechanics of injury, and we discussed the premise of the positive stretch sign, which it really takes a long time to explain. So those of you who will be taking some of our courses in the future, you'll have the opportunity to learn more about the positive stretch sign. But trigger point pain is very prevalent. As you can see that in pain practices, pain due to myofascial trigger points can range between 85 to 93%, while in a regular orthopedic practice specializing in lumbar spine, 21% of the patients in that clinic had pain in their back because of myofascial trigger points. So very quickly, another quick question to you. I would like to find out, before I discuss about myofascial trigger point therapy, how many of you utilize routinely in your practice myofascial trigger point therapy? So it seems that almost everybody utilizes myofascial trigger point therapy. Some of you more than others. Some of you want to learn a little bit more about it, and probably 7% of you does not utilize currently myofascial trigger point therapy. So myofascial trigger points can be activated due to either micro or macro trauma, or it is also possible to have latent trigger points that will become activated. Latent trigger points are trigger points that can be in the area for a long time that will limit range of motion. They will decrease muscle strength in the area. They will refer pain, though, only when we apply ischemic compression on them or when you stick a needle. So the difference essentially between an active and a latent trigger point, for the most part, there may be several differences, but the greatest difference is that the active trigger point will actively produce pain even when you do not apply any pressure on them, while the latent trigger points will not produce pain unless you apply either compression or you put in them a needle. So also, myofascial trigger points have three major components: a motor component, a sensory component, and an autonomic component. So when we say motor component, what we mean is a disturbed motor function, muscle weakness, of course without atrophy, because we're not talking about a denervation here of the muscle, but also muscle stiffness and restricted range of motion. Now, this is very interesting. Disturbed motor function can actually lead to muscle imbalances. Myofascial trigger points may either excite or inhibit motor activity in the muscle of origin or in a functionally related muscle. So when you have a myofascial trigger point in a specific muscle, it's possible that that myofascial trigger point can inhibit or excite that specific muscle, or it may inhibit or excite a muscle that is functionally, that has a functional relationship with the affected muscle. I'm going to give you some examples, such as the trapezius muscle. The trapezius muscle, if it is myofascially involved, will inhibit the muscle itself. The infraspinatus muscle will inhibit the anterior deltoid. The quadratus lumborum can inhibit the gluteal muscles. And when the tensor fascia lata is myofascially involved, it can actually excite the paraspinal muscles. So think about this. In a case where I have a myofascial trigger point in a specific muscle that inhibits or excites that muscle and other muscles that are functionally related to that, I'm going to have then in a specific area some muscles that are inhibited and some muscles that are excited. If I have inhibited muscles, that muscles tend to become weak. If I have hyper-excited muscles, those muscles tend to be more hypertonic. They tend to become stronger and more hypertonic, actually, not necessarily always stronger, but that will create a myofascial imbalance. We can see that Yanda, for example, mentioned 4 different conditions as postural syndromes due to myofascial imbalance, due to muscle imbalance. So let's talk first of all about the forward neck syndrome. In the forward neck syndrome, you are going to have a tight and of course shortened sternocleidomastoid, while at the same time the scalenus muscles will be weak and inhibited. So the occiput and the upper cervical spine will be hyperextended with the head being pushed forward. And then we have what is called the upper crossed syndrome. In the upper cross syndrome, you are going to have tightness and shortening on the pectoralis muscles, the upper trapezius, levator scapula, of course, and sternocleidomastoid, while at the same time, the lower traps, the middle traps, the serratus anterior, and the rhomboids, they're going to be very weak. So it's in a criss-cross pattern. That's why it's called the upper crossed syndrome, which is a pretty bad myofascial imbalance, a postural imbalance, that not only will cause this hyperextension of the upper cervical spine, but also it will cause a rotation and abduction of the scapula, anterior rotation of the humerus, creating greater stress in the upper trapezius, levator scapula, supraspinatus muscles to stabilize the shoulder. And of course, this position can have a horrible negative effect in breathing, which in some cases we can see that in paroxysmal breathing. So this is something that we should look out on patients with cervical spine pathology, because the problem may start up here in the cervical spine, but it can migrate down into the thoracic spine. And as you are going to see in tomorrow's presentation, if we do not handle this, that can migrate even lower and create what is called the lower cross syndrome and the stratification syndrome. We'll talk about the other 2 syndromes in tomorrow's presentation. But also, myofascially involved muscles are weak muscles. You can see here a picture of the length-tension relationship curve as it relates to the sarcomere arrangement. You can see that when we have a short muscle where the sarcomeres are all bunched up together, the muscle can exhibit only a small, the muscle can exhibit only a small percentage of its maximum force. And the same will happen when I have an overstretched muscle. Remember that the tension that the muscle can develop is directly proportional to the number of cross bridges that can be formed between actin and myosin filaments. So if I have on a shortened muscle a lot of overlapping between actin and myosin filaments, I'm not going to have enough new cross bridges being formed, and therefore the tension that this muscle can develop will be very limited, and this will be a weak muscle. And we see time and time again in patients who come with myofascial trigger points where the muscles are very shortened. After we work on the myofascial trigger point and we resolve the myofascial trigger point and we stretch the muscle strength improves without doing any muscle strengthening exercises, but just doing the stretching exercises. That's the muscle shortening I was talking about. And definitely, if you are talking about very tight muscles, that will affect tremendously the paraspinal area, because number one, if I have tight paraspinals or tight muscles who are near the spine, the sternocleidomastoid is one of them, the scalenus another one, those muscles will increase the intradisc pressure. It can cause either arthralgia in the facet joints, but also can become one of the factors that eventually can lead, it can become a predisposing factor for a disc herniation. Now, besides the motor component, myofascial trigger points also have a sensory component. You may have local pain, what is called peripheral sensitization, but also ectopic pain, central sensitization, and of course, referred pain patterns. So local pain or peripheral sensitization happens because when we have a micro or a macro trauma, we have release of various cellular metabolic products, such as histamine, serotonin, bradykinin, P substance, prostaglandins, luteinins. So all of these sensitization nociceptive substances will trigger peripheral pain and will cause a peripheral sensitization by decreasing the pain threshold of these peripheral nerves, the peripheral nociceptors, and therefore increasing the pain stimuli that travel from the periphery to the center. But also we may have ectopic pain. Why ectopic pain? Because these substances that I talked to you about not only will hypersensitize those peripheral nociceptors, but also can destroy the myelin around the nerve axons and around the nerves. And when the myelin is destroyed, then it is possible that stimuli from one nerve, impulses from one nerve can jump over and ectopically stimulate an adjacent nerve, and therefore we can feel a magnification of the pain phenomena due to ectopic pain. And of course, we can have a central sensitization, which is a very, very important phenomenon that we see especially in chronic pain cases. And of course, referred pain patterns. What is referred pain patterns? Referred pain, especially when talking about myofascial trigger points, is when the myofascial trigger point is located in one specific area, but the pain has nothing to do with the area of the cause of the pain, but the pain is in a distant area from the area of the myofascial trigger point. So what is the reason for that? Well, there are several theories that pertain to the creation of referred pain patterns. Some of these theories discuss the phenomenon of a phaptic transmission. In a phaptic transmission, we can have a nerve impulse transmitted from one axon to another axon due to the focal demyelination that happens in these sensory nerves. So when the myelin sheath is stripped from the sensory nerves due to the presence of myofascial trigger points and those nociceptive substances that are being secreted from those myofascial trigger points, I can get stripping away of the myelin of these sensory axons, and therefore via a haptic transmission, I can have referred pain. But also, I can have what is called crosstalk. Crosstalk will be when the damage of the peripheral afferent sensory fibers will result in a hyperexcitability of these damaged nerves and the transmission of action potentials along adjacent, undamaged, unstimulated sensory fibers. So these fibers are really damaged. These fibers here are not damaged, but the stimuli from the damaged fibers can crosstalk, can cross over the undamaged fibers, sending up to the central nervous system painful stimuli. And finally, we have what is called the expansion of receptive fields. If you have persistent painful stimuli, that can result in increasing the number as well as the size of the receptive fields to which a specific dorsal horn nociceptive neuron corresponds to. So this can result in an increased referred as well as spontaneous pain. And then we have autonomic phenomena such as a pilomotor reflex. One of the things that we observe in our patients and of course in the lab sessions of our seminars is that when you apply compression, let's say, on a specific muscle that is myofascially involved with an active and sometimes with a latent trigger point, you see that the skin near the area of the compression of the myofascial trigger point gets goosebumps. That is called the pilomotor reflex. And of course, you can have vasoconstriction or vasodilation, dizziness, lack of balance, which are proprioceptive disturbances, and also tinnitus, tearing, and as well as rhinorrhea. So clinical symptoms of myofascial trigger points can include local pain, as I said, referred pain, autonomic and proprioceptive disturbances, edema, cellulite, and sleeping disturbances. And in terms of physical findings, we can identify a taut band and also several other physical findings that we discuss extensively in our courses, but this is what we are talking about when we discuss the taut band on a myofascially involved muscle. What happens is the following. If you palpate perpendicular to the fibers of a myofascially involved muscle, you will identify something that feels like a piece of rope, something that feels like a guitar chord. That is called the taut band. And then, if you palpate across this taut band, you will identify a nodule, which is what is called the contraction knot of the myofascial trigger point. And this is the nodule and the contraction knot that makes up the nodule. Also, upon insertion of a needle, we observe what is called a local twitch response. A local twitch response is a depolarization of the muscle membrane that has a very, very positive effect in a case of a trigger point. You see, one of the things that I will not have the time to discuss with you is the entire mechanism through which a myofascial trigger point is being created by. But in a case of a myofascial trigger point, we have excess of ACH in the synaptic cleft. So the more ACH you have in the synaptic cleft, the more hypertonic the muscle becomes, because you have a constant partial depolarization of the post-junctional membrane. And therefore, when you use a needle in the area of a myofascial trigger point, the technique is called intramuscular stimulation or dry needling technique. By using that dry needling, you produce multiple depolarization, multiple twitches of the muscle, and those multiple twitches consume the excessive ACH that exists in the area, and then the muscle can relax. You can restore the blood circulation. We give a great emphasis in the biomechanics of injury. And the reason is, if you look only at the referred pain patterns of myofascial trigger points, you cannot really use that as your only criteria to decide which muscles to treat, because many muscles refer to the same area. For back pain, for example, that I'm going to be talking about tomorrow, I can have the paraspinals referring to the back, the iliopsoas, the gluteal muscles, the quadratus lumborum. There's a whole bunch of muscles that can refer to the lumbar spine. But how can I choose what muscle to treat? So I use an entire evaluation system to decide for that. But part of that evaluation system is looking at the biomechanics of injury, looking at the specific biomechanical factors that can affect a specific muscle. And when I decide what is the muscle that is biomechanically involved, and I can corroborate that biomechanical involvement with the referred pain pattern, then this is the muscle that I choose to treat. So we have an entire myofascial evaluation sequence that includes all of these components that will lead us to decide to the proper muscle system to treat. This is just from our book, from page 21 from our book, for those of you who have the book, that discusses the pathogenesis of myofascial trigger points, the specific mechanism for the creation of myofascial trigger points. By the way, the book is available at handsonseminars.com or at Barnes & Nobles or at Amazon.com. Now, palpation of myofascial trigger points can be done either flat with one of our digits, or we can use what is called pincer palpation by pinching the muscle. And the technique we use is called the progressive pressure release technique, where we apply gradual pressure for at least 45 seconds on the myofascial trigger point. Then we gradually apply more and more pressure, and then after the application of the progressive pressure release technique, PPRT, then we always follow with myofascial stretching, and the stretching has to be very, very slow and must last at least 30 to 45 seconds per position. You can see here the application of myofascial trigger point therapy with ischemic compression on the sternocleidomastoid muscle utilizing the pincer technique, and followed immediately by the myofascial stretching of the muscle. And obviously, we give to the patient home stretching, home exercise programs to do. And it is very important to avoid what are called perpetuating factors. If you have someone who has the bad habit of putting the pillow under their shoulders and reading a book, then look at the sternocleidomastoid muscle, how it becomes overactive and becomes a perpetuating factor for this condition. Same thing when someone sleeps at night and they have myofascial involvement of the sternocleidomastoid and the scalenus, they must place their pillow not under the shoulders, but between the top of the shoulder and the neck. And I will discuss with you at this point, and I'm sure there might be some questions. I'm going to discuss with you, though, at this point, a few concepts about the strain counter-strain method. And I want to ask how many of you know and utilize the strain counter-strain technique. So I see that some of you, about 9–10% of you, don't utilize strain counter-strain at all. We have about 40% of you that utilize it, and 53% of you, 50% of you, it keeps changing as you are voting, that you would like to know more about strain counter-strain. So strain counter-strain was developed by Lawrence Jones. He was influenced by the osteopathic model, and the strain counter-strain technique, the whole theory discusses the fact that the dysfunction of the area is in the muscle spindle and the primary proprioceptive endings. Actually, the concept that Jones supports is very different than the concept that Bell, Simons, and other researchers in the area of myofascial trigger point support. So Jones supports that the primary focus, the primary area, is the muscle spindle, while Travell and Simons and other researchers believe that the trigger point is an actual entity, a histochemical, physical entity in the muscle, and does not have anything to do with the muscle spindles. So here is what I have a few slides that I'm going to present them to you, but as the concept to understand it and break it down for you very easily, I prefer that you look at me. And I'm going to use the example because this part of the course, the strain counter-strain part, my associate, Mr. Rizopoulos, is teaching, but I will use exactly the same example that he uses in his lecture. Let's suppose that we have someone who is either writing something or someone who is gardening, let's say. When someone sits in the garden, gardening, they are in a slightly flexed position of the cervical spine. So in this case, the flexor muscles of the cervical spine, they are shortened. We'll see it here in a picture. The flexor muscles are shortened, while the extensor muscles, they are going to be slightly stretched. So the flexor muscles, because they are shortened, as you can see here, they are going to have very low firing. Their spindle will be firing very, very low, while the extensor muscles, that will be slightly stretched, they will have a greater firing of their muscle spindle. And as a matter of fact, because the extensor musculature is stretched, via reciprocal inhibition will produce even a greater inhibition and relaxation of the flexor musculature. So as I am gardening now, and I am in this flexed position where my flexor muscles are flexed, relaxed, with an underfiring of their spindles, and the extensor muscles, they are stretched and more firing of their spindles, another thing happens. In order for, as this sternocleidomastoid and flexor musculature is flexed, the gain of the muscle in terms of its firing increases. The muscle becomes more sensitive. So, and that happens because of the increased relaxation of the muscle. The sensory threshold of that muscle decreases. So let's suppose that at this instant that all this happens, the phone rings, and as I'm in this flexed position, all of a sudden I have to go up into extension to answer the phone. So what happens is, because the threshold of the flexor muscles has decreased, this extension of the cervical spine is being perceived by the flexor system as a hyperextension, as a quick hyperextension. And therefore, the spindles of the flexor musculature not only overfire, but because they overfired while the muscle was in this compromised position, they become dysfunctional. I know I can see a whole bunch of questions which I will answer at the end, I promise. But this now dysfunctional spindle needs to gain its functionality again. So what Jones says is that if we place this muscle in a position of ease, in other words, in a shortened position, we can reset that muscle spindle to its original firing state. So let me just give you an example here that in terms of treatment, what you will do in this case is you will actually, let me just give you the next slide and I'll come back to this slide. I'm going to utilize as an example the upper trapezius. So what you're going to do is you are going to take the patient and start palpating for various areas of tenderness. Once you identify an area of tenderness on the upper trapezius muscle, you tell the patient to give a number 5 or a number 10 in terms of intensity of that tenderness. And then you start moving the head and the shoulder in such a position called the position of ease, which is a position of shortening of the muscle. And you get feedback from the patient as you move the head and the shoulder into a shortened position, the position of ease. You get feedback so that the pain is only 1 or 2 or 0. Once that happens, you maintain this for 90 seconds. And according to Jones, these 90 seconds are enough to reset the muscle spindle and resolve the problem. So this is the basic idea. In our courses, we can teach not only the Jones pure model, but we also teach the model introduced by Leon Chato called integrated neuromuscular inhibition technique. And during that technique, we are combining myofascial trigger point therapy combined with the Jones strain counter strain and what is called micro stretching. And finally, I will discuss tonight the concept of muscle energy technique. And again, I will answer questions very, very shortly as soon as we are done with the course. But I would like to ask all of you, how many of you use muscle energy technique routinely in your clinics? So I see that the vast majority of you do use muscle energy technique, but about 58% of you, and then we have about 17% that they are not using muscle energy technique, and about 30% of you use it, but you would like to learn more about it. So now let me talk a little bit about the muscle energy technique. Muscle energy technique was developed again by the osteopathic model, and Andrew Taylor Steele, the father of osteopathy, basically influenced many of the subsequent osteopaths, such as Fred Mitchell, who developed the initial premises of muscle energy. Discussing the muscle energy, I must talk to you about the barrier concept. So what is the barrier concept? You know, in every range of motion, you have a physiological barrier and a pathological barrier. So what do we mean by that? So if, for example, I'm going to use my elbow here. If this is the normal range of motion of my elbow and I sustain, let's say, a fracture, so I have a limitation, I try to do elbow extension, and while this was going to be my physiological barrier, now because I do have a compromise in the range of motion, I cannot bend the elbow as much, so I have a limited extension, and therefore that would be the pathological barrier of my motion. Now, in addition to the physiological and pathological barrier, I have what is called the anatomical barrier and the paraphysiological space, which I am going to show you right now. So, this is the beginning of your range of motion, and as we said, you have your physiological barrier. And because you have a dysfunction, you have a pathological barrier. But if, for example, for the elbow, the normal range of motion is, let's say, 180 degrees or 0, whatever you want to call this, that does not mean that I do not have some additional play in the joint. So I do have another barrier, which is called the anatomical barrier, and we define the anatomical barrier, essentially it's the final frontier, is that barrier that if I try to go further beyond that, I am going to observe lysis in the joint. I'm going to destroy part of the joint elements. And there is a space between the physiological and anatomical barrier that is called the paraphysiological space. So, here is my question to you. When you work on a patient and you treat the patient today, a patient that has this limitation in their elbow, and you treat them and you manage to gain an increase in the range of motion, let's say by 10 degrees. You treat the patient today. The patient comes back to see you in 2-3 days. Does the patient maintain the proper and the full range of motion? Will the patient maintain the 10-15 degrees that they gained during your session, or the joint will stiffen up and you're going to gain maybe 5 degrees? This is what happens in most cases. When your patient comes back, is not going to maintain the entire range of motion, they will have a little bit less of that range. So, perhaps then, we should assume that if you work with the patient until the patient reaches what is called normal range of motion, let's say 180 degrees, and then you discharge the patient, in the weeks to come, they may not maintain the full range, but they may stiffen up a little bit again. This is why when we do our treatment, and in order to achieve a proper full range of motion, we must not only work up to the physiological barrier of the range of motion, but we need to go into the paraphysiological space to reach the anatomical barrier. So even if the joint stiffens up, to be able to still maintain our physiological barrier. So there are two forms of muscle energy technique, post-isometric relaxation and reciprocal inhibition. So in post-isometric relaxation, you contract the agonist muscle to relax the same muscle, while in reciprocal inhibition, you contract the agonist to relax the antagonist. For example, let's take the scalenus muscles, okay, as an example. If I want to relax my right scalenus, or left for you now, I don't know if, I think you see my mirror image here. If I want to relax this side, I will contract this side. So via the phenomenon of post-isometric relaxation, I will relax this side and I will stretch on the opposite side. While in reciprocal inhibition, if I want to relax this side, I will contract the opposite side so that this side can relax, and then I can stretch the muscle. So that would be the reciprocal inhibition. Now, what is the physiological mechanism of this? For post-isometric relaxation, it works through the Golgi tendon organ. So when you get a strong contraction of a skeletal muscle, the Golgi tendon organ will transmit via the 1B afferent fibers up into the spinal cord an excitatory stimulus that will excite an inhibitory mediator. And this inhibitory mediator will inhibit the alpha motor neuron to that same muscle. And therefore, the muscle will relax for a few seconds after the strong contraction. Now, for the reciprocal inhibition, that works through the concept of the muscle spindle, and I can have a contraction of this agonist muscle, and that will activate the muscle spindle, which will then by its turn stimulate and excite an inhibitory interneuron that will inhibit the action of the antagonist muscle. Both of these processes are normal processes. They are normal processes that the body is using to protect itself against injury. So we take advantage of these two physiological mechanisms in order to help us stretch, relax, and then stretch a tight muscle. But despite the fact we have two forms of muscle energy technique, we have three protocols. First of all, we have the Carrel-Levitt protocol or Carrel-Lewitt protocol. In this approach, what we do, and I'm going to show you again myself, you are going to move, let's say, the hypertonic muscle at the barrier, and you're going to do a very, very gentle isometric contraction, and then after you apply the gentle isometric contraction, you are going to allow then the muscle to relax into a new position, and you will repeat it again and again 3-4 times, and moving to the next barrier and the next barrier until you achieve the outcome you want. In our regular seminars, we spend a lot of time to go over each one of these techniques with a lot of examples and a lot of different muscles, but quickly I am giving you a very brief idea now on how this works. The second technique is the Yanda post-facilitation method, What we do with the Yanda post-facilitation method is we bring the shortened muscle not at the barrier but at the mid-range, and we apply a maximum isometric contraction, a very strong isometric contraction. And when the patient relaxes, then very quickly we move to the barrier and we hold it for 10-15 seconds. Then we relax and we allow the patient to relax for 20 seconds before we repeat the same process again. So I want you to notice that in both the Levitt and the Yanda method, I contracted the affected muscle and therefore I utilized the form of post-isometric relaxation, that form of muscle energy technique. The opposite happens for the Evian protocol. In the Evian protocol, what we do is we actually put the muscle into the shortened muscle into mid-range, and we apply now an isometric contraction to the opposite muscle, to the non-affected muscle, utilizing the principle of reciprocal inhibition, and then we stretch the affected muscle. Now somebody will tell me, when do you use this? When do you use that? Why do we have three different approaches? Well, actually, in clinical practice, we see that these three different approaches are very applicable. And when it comes to the Levitt approach, we use the Levitt approach especially in subacute cases, and the Yanda approach in chronic cases, while in very acute cases, we utilize the Evian technique. And this is easy to understand, that if I have, for example, injured my right scalenus muscles and I am in a lot of pain on the right scalenus, I have a lot of tightness, muscle spasm of the right scalenus, if I'm in an acute phase, if I contract the same side, that will cause even more exacerbation of the symptoms. So I utilize the Evian approach to apply contraction to the opposite side, and then I go and stretch the affected side. When the problem becomes more subacute or chronic, then I can utilize either the Levitt method or the Yanda method by applying the shortening, by applying the isometric contraction on the affected side. So this is the reciprocal inhibition post-isometric relaxation and three different forms of muscle energy technique. And what I'm going to do at this point is to actually take some of your questions. I will open up the questions here. So let's see, what questions do I have? Oh my God, I have a lot of questions. Okay, some of you, I see that you have not been able to view the screen properly, and some of you that you have not been able to see the camera, or you have been able to see the screen. I will try to fix this and make it available to you in a recorded format. However, what I would like to let you know is that you can see, you can obtain CEUs, and a certificate will be emailed to you to your email address that you utilized to register for this webinar after you fill out the survey that was provided to you here. So once you are able to fill out the survey that will be provided as soon as I end this webinar, you will be receiving tomorrow a CEU certificate that will be emailed to you. Also, I would like to remind to everyone that in tomorrow's webinar at the same time, 7 p.m., we will be discussing lumbar spine pathology